putting the,
Yes,
all right,
we can.
thank you. All right, let me get this started. Just give me a second. Okay. Okay. All right. Welcome everyone to this session. My name is Patrick Oyulu. I'm the Health Promotions Program Manager at NJOR, and I'll be taking you through a session for delivering effective and compassionate services for older refugees. Um, Welcome once again, and apologies for the technical hitch that we had in accessing the room, but I'll try as much as possible to take you through this session in the allotted time. And if there are questions and answers, we shall go through, we allot appropriate time for that. The learning objectives for this session is that by the end of the day, we can explore this unique demographic of older refugees amongst us. And these are refugees that we serve. Actually, amongst one of my portfolios is services for older refugees. So this is what we attempt to see, to try and see how best our programming can be more compassionate with empathy and understanding their needs. So we're also going to define cultural competence in the context of aging and how it applies to older refugees, identify specific health and wellness needs of these refugees, and how to tailor programs to effectively, meet their needs. I understand that we have some of the agencies that are dealing with older refugees, and you interface with them on a daily basis, basically seeing a lot of the trauma that they, some of them exhibit, and the vulnerable situations that they come from. So we attempt to try and, lift them up, leverage on those social skills that they come with and the social capital that they have, and try and do some programming around that to actually lift them, understanding that they are coming from a situation where they really need help. And then at the end of the day, we'll also be able to explore ways to foster community integration and social inclusion for these, and extract the best practices that you are already dealing with or trying to exhibit out there, but we could share amongst us, because I believe that this is a sharing kind of forum for all of us at the end of the day, to learn from each other, to learn from what challenges we are trying to face out there, and then try and see how we can then best find interventions that moving forward can actually help this cohort. Now, before I go, we have any further, we have a Slido that I would just want to find out from you. We have 13 participants here. If you can, get off your phones and, scan that barcode. I just wanted to see if your agencies provide. Great. Right now we have 100%. Almost all of you. We agree? 100%? Good. That is fine. And I appreciate the fact that you've made an effort to come here to learn from each other. As we go further, I would just give an overview of the cohort we are dealing with. We have a vulnerable community of old refugees amongst us. They're not so many according to the demographics, but still enough to elicitate that kind of response that we as providers, have to do to actually meet their needs. So like every senior citizen in our community in America, and there are so many, they come with very many needs. They come with physiological needs. They come with emotional needs. And in their situation, they're coming with trauma. Most of them are vulnerable. So the issues to do with self-isolation, mental health, that is really very, 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 very important. So they come with all these experiences when they are resettling. And, as they age, society does not even treat them in the best way that you would expect. Integrating within society is really challenging for them. And now you remove them from their countries of origin, you remove them from their cultures and integrate them in a new society. They will go through a lot of adaptation issues. They will go with a lot of barriers that come with this, and a lot of cultural nuances that affect their psyche, their mental health, and their general well-being. And in terms of health outcomes, you find that really can affect them psychologically. Would really that would really affect them psychologically, and that also has a way of dealing with the environment that they live in. So this session is to find out ways how we can address these needs effectively and compassionately. And like I stated in the previous sessions, do programming within an equitable lens, to understanding them, understanding where they're coming from, understanding their languages and their cultures, and then trying to, do programming that actually helps them. Now, I have just placed a rough demographic overview over time that shows you the different age limits or the age groups that are coming in, and you shall see that the older people actually are very, very few. Actually, the next slide will just go ahead to let you know or see that they come from a span of countries. If you see from 2013 to 2022, we've got a lot of refugees coming from different regions. And what does that suggest? It suggests different cultural, upbringings, different languages, different experiences. But what we are not yet seeing is an actual serious breakdown of the older refugees. And this is what we are attempting to do in our interventions right now. Once we move in the different agencies, we are seeing a buildup of older refugees. I was in CWS recently, and there's a lot of refugees in that cohort, and they come from different backgrounds, from Afghans, from Ukrainians, from Haitians, from Venezuelans. So I would want you to go into Slido again, and then just tell me what in your view poses the biggest barrier to older refugees. I see social isolation. Any other thoughts? Language proficiency, social isolation, transportation. Wow. Almost similar. Right. I see language proficiency is a problem, and this is across the board with all the cohorts that we get. There's difficulty in language, and which subsequently translate in difficulty in getting the skills they need to on services that they need. They're finding it hard to actually communicate and integrate. They're finding it hard to, just belong, as in like belong. That sense of empowering is not there. So our role is to try and uplift them. Anyone would like to actually tell us about the barriers, maybe expound more in terms of sharing? Maybe you could just unmute and, tell us your experiences.
Hello, my name is
Hello.
David.
Yeah, David.
I'm the SOR coordinator for Interfaith Rise. I noticed that a lot of our clients struggle with the social isolation. They don't really have the community because they left their community behind, and then here it's harder for them to integrate into social groups than younger groupings. And I also noticed big issues with like transportation and technology. Since some of our older refugees are not as comfortable with technology and things like that, it makes it harder for them to access different services.
Thank you, David. And thank you, iRise, for the work you do with refugees. I've visited iRise and I've seen the extraordinary work that you are doing. Could you tell me, David, there's that element of peer-to-peer groups that would actually try and help refugees or older refugees of a like-minded cohort? How is that working with your teams? Because looks like it's something that you're trying to do.
Absolutely. So, what I have noticed is that also iRise is a little bit different because we are so spread out. Our clients are so spread out geographically. But within the group of seniors that we have enrolled in our SOR services, we've noticed different language groups. Vast majority is Ukrainian. So when we can do things when we do things, we normally get big groups of Ukrainians, and then the other clients seem a little hesitant to join into those social groupings, probably because of language, because maybe, of representation. I'm hoping that as we increase our enrollment and diversify our population of older refugees, that will get better slowly.
Thank you, David. I also noticed the issues of transportation, and specifically, I'm sorry to always jump towards the iRise, but basically, there's that issue of outreach, or that issue of like voluntary transportation to go and do certain things like maybe screening and all that. Could you walk us through that as part of some of the mitigation measures you're taking as iRise?
Absolutely. I mean, we're lucky at iRise that we do have some really involved volunteers that do help us in terms of rides. What we've noticed, however, is that because the seniors are spread out, it seems that our seniors are spread out geographically even more than just our general population. And so sometimes we are able to get rides and offer rides, but if we don't have volunteers in a specific region, in Middlesex County, Mercer County, we have good volunteers. We have really good, but as things get more south towards Burlington, it gets a little bit more complicated, or towards Ocean County, just because we're starting to increase the amount of clients that we have in those areas. So we have some isolated pockets where it's pretty difficult to get a volunteer to pick up the clients, or to, we're trying to also target some events in their area so that it's less of an issue with transportation. And we're also trying to connect our older clients to the direct resources in each individual town that they live, such as their senior centers, their food banks, their libraries, etc., so that it fills that gap, right? Because there is, between Highland Park and breaking up, and we're trying to try different ways to make things closer.
Thank you, David. Sorry, your mic was breaking, but I got the gist of what you are saying. You are actually trying to reach out there, trying your best outreach efforts, trying to get all your volunteers, but you're spread out to areas where it is very, very, very difficult and challenging sometimes to even get some of those volunteers. But that attempt is being made. In terms of transportation, for example, I'm working already on a pilot, and I'm hoping to involve the agencies in trying to reach out to the people, the communities you're working with, to see how best transportation can be less of a barrier. Or I know it is being done right now, but how best to scale it to a certain level that at least uplifts them even a notch further. That is something that I'll be getting in touch with the various teams in the agencies. Let me just clarify some of the messages in the chats. I think someone stated that this program looks like it has been scheduled for tomorrow. If that was there, then I think that should just be an oversight on our part. Tomorrow we have another program on cultural nuances that affect the different program deliveries in amongst our jobs that we do. Today it is just trying to deliver to a particular cohort, which is services to older refugees. I hope that clarifies that. I'm sorry for any oversight on our part on that. All right. In terms of challenges and faced by older refugees, we already have healthcare barriers. We see a lot of that that they come with. Like any old person, you succumb, or at least exposed to different risks that come with aging, and different physiological and mental kind of needs that come with aging. And the fact that refugees are actually coming from their homes where they've been displaced from, or are seeing various situations, it really affects their health care. I can give you a testimony from South Sudan, where I deployed to in 2013, when South Sudan was going through serious war, and it has been going through that. So I worked for a refugee agency in the remotest parts, and the issues of trauma was really so live, and we saw it, and it affects them to the extent that once you provide durable solutions like relocating them or resettling them, they come with some of those those experiences. It affects their health, it affects their healthcare. But now once they resettle, you have issues of discrimination, you have issues of literacy, others are coming with issues of language barriers. And then specific to that region that I went to, it's a patriarchal society where you find that there's a dominant, male in the homestead, and then the females are supposed to do certain roles. So even interventions to go and talk to them about sexual health or sexual reproductive health is like a taboo. So some of these nuances that these communities come with, they come with different mindsets that we should be mindful of, and then try and work with them to understand. I'll give you an example here. We have a huge surge of CHEs and a big Haitian community, but the uptake, for example, in screening is challenging due to different cultural issues. It could be stigma. It could be that mental health is seen as a taboo. So that is generally speaking to all the different cohorts, but becomes even very, 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 very difficult when it's faced by the elders, the older people who may not have someone to advocate for them, someone to, help them understand some of the issues. So they risk getting into, social isolation issues, and that ultimately affects their mental health. Speaking of social isolation, these are the statistics we are seeing around, about why people feel isolated, just generally, and this also affects, our cohort here, because like you see, some of them in America, people are going out to work, even the caregivers and all that. People are working, families are working. So you find a person has resettled with a younger cohort of people who constitute their family but have got to go to work out there. He's being left alone. So what supports are there to keep him engaged, to keep him getting out of that feeling of isolation? And it's a big problem which is prevalent not only in the refugee community, but even broadly speaking to the older community. But like David was saying, there are a lot of referral sources out there in mental health, in the different counties that they can get access to. And in all the counties from Middlesex, Bergen County, Passaic, Hudson, all those have offices of the aging, and these offices of the aging have different activities that they can actually supplement on what agencies and providers are doing for this type of cohort. The next slide here also points to some of the other difficulties that the older community may be having, in terms of being financially deprived. They mostly at an age where even getting into the workforce is problematic, so that feeling of not being able to provide that you had when you were in a different, or you're in a mother country in the past, points to an issue of self-esteem. And in certain families, that is really very, 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 affects their psyche. It affects how they feel they are perceived in society. So it points to social esteem issues that we have to work as providers, work to try and elevate, to try and mitigate, and try to ensure that they feel that they belong, they feel that they can make certain decisions. And that is very, very empowering. Then, of course, we have the issues of religion, cultural issues, and to work all around. So this is just a whole snapshot of the different issues that these older cohorts really are facing. So how do we provide enabling supports? Anyone out there could give us an example of what they are doing with their refugee communities, especially the older ones, that tries to empower them, be it maybe learning technology, maybe taking them to the senior centers, or having those activities that brings like-minded in one sitting for activities. Maybe it is yoga, or, those activities that feel that they belong and not make them feel isolated. Anyone in the cohorts who would like to share? You could actually just send it in the chat, or you could unmute yourself and just let us know what you have done to help them. How have you leveraged on what they're going through to improve on their maybe social networks, peer-to-peer support groups? What are you seeing out there? Right. Let me go to the next slide. So basically, we have to tailor, or providers have to tailor, the programming that they're actually dealing with right now, by trying to understand these clients from a cultural perspective, from a trauma-informed kind of way, knowing what they have been through, in order to then devise, programming that is culturally sensitive or culturally appropriate, having multilingual health information. I've seen that in the different agencies I've gone to. Most of the health information that you have is translated in the different, languages, be it in Ukrainian or Haitian. And then also having culturally competent staff. The staff that I'm proud that some of the agencies already have and are already doing are people who come from those different cultures. Or, it's just not only appropriate in being language, specific, that the language, but if you understand the cultures, you're able to actually, relate to these cohorts. It's all about building trust at the end of the day. If you work on building trust with these clients that we're dealing with, they will actually go, a way higher in, opening up, in going and accessing the services that you refer them to, other than just, pulling back and then, being in that silo. I've spoken about peer-to-peer supports. I went to CWS and they had this session on SOR, and there was also health education there. And this group had, it was mixed. It had the Ukrainians, it had Afghans, it had Venezuelans, it had CHEs, and just bringing them together in group educational forums is very, 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 very important. I know certain agencies deal with some of these issues at an individual level, which is also okay. But it's best when you have all these peers together, as one group, and then all trying to, come up with ideas or solutions or share experiences. That is very good, not only for their mental health, but also just as a way of empowering them, And some of the things agencies and providers could do is look into ways of, being flexible in scheduling various things around these clients. Because they are not like your younger cohort ready to go. These are people who, of course, with age are also getting challenged physiologically. So they need time, and then mentally also to try and adapt is a problem. So flexible kind of scheduling of the various activities is something which is very, very important in your role as a provider dealing with this community. And then, of course, there are also nutritional challenges or considerations. These are old people, and with time, you find that we all have, as we age, are mindful of the different types of nutritional additions that affect our bodies. So as far as your programming and provision is, try and understand where they come from and what also would help them, build their health themselves, in terms of nutrition, in terms of activities. And then, of course, the overarching thing is also just the translation services. How do they communicate? Because once you do not communicate effectively with them, it's so hard to come to a common ground, to be heard. And right now in their situation, they are so vulnerable. They need to be heard. Who else to advocate for that than the providers, to hear them, to listen to what they have to say, and then, take it from there, give them a lending hand, and then refer them to those services that they really need. So in short, the tailored services that we have to do around or conduct around in our programming should culminate in one thing of building trust. And how do you build trust? You build it by being a service to the other without expecting, you're doing a service without expecting that they also have to render that back. In the humanitarian world, we are here to do a service. We have to respect each other. We have to show that there's that sense of trust, and has to be manifested in an honest manner. And if we do that, we get into that comfort zone where that refugee will always look out that, this provider actually provides this type of services, has helped me, and can empower them to even reach out to other people yet to be seen in the communities, and then point you as the provider as the go-to provider, that cares, is compassionate, is honest, and is able to actually service this need. At the end of the day, you're building a community, and this is the whole essence of working to build all these refugees that are coming in. Build a community that's based on trust, build a community that is able to settle, and is empowered to go and become self-sufficient. But at the same time, not forget where they're coming from in this community that has helped them resettle. Build those community networks. It's a key tenet of health promotion. It's a key tenet of keeping people and empowering them together, to be respectful, to have a sense of purpose, a sense of belonging. Who doesn't want to have that? All of us want to do that. So these are kind of small attributes that we have as providers to provide to them, to make our caseworkers know that we've got to be culturally competent. We have to understand where these people are coming from in order to devise best practices, that will help them. Specifically, when we talk about cultural competence, I've listed down what it fosters: effective communication, understanding and respecting languages. It enhances trust and rapport. It creates that trust not only between your staff, but also with the older refugees. So your staff actually can then develop personalized care plans around these unique challenges that they face. And also, it promotes a workplace culture that values diversity. That's very, very important. I've seen that most of the providers we have different staff from different areas. So if we can foster that value of diversity, that will ultimately create an inclusive environment. I must thank you all for being able to work in those environments and actually enable, that growth, in that type of environment. That is very, very important, not only to you, but to the people you serve. And ultimately, what this may also help the staff is that they become cultural mediators. They are the ones who advocate. They're the ones who bridge the gaps that these older refugees that you're serving may have in the questions that they have. And they really go through a lot in navigating health, in, integrating into community. But once they have that person in you, the provider, and your subsequent staff, who then can advocate and bridge all those gaps that they are facing, that's very, very important. And lastly, cultural competencies also recognize the potential trauma experienced by older refugees, can contribute to better mental health supports. Social integration, it improves mental and physical health through connections. reducing feelings of isolation and loneliness. Integration can lead to increased workforce participation, allowing all the refugees to contribute to skills and experiences to their economy. Integration also improves resilience, because once you strengthen social ties, you aid mutual support, that regular interaction is very, very, very important. It also ultimately will help the older refugees reduce dependency on social welfare programs. Once they go out and integrate positively, they then at the end of the day reduce the dependency that the welfare system is trying to help them with. We know that that system is already backed up, and there are other people that need those priorities. But if you have an empowered cohort of people who is then weaned out of this dependency by their own actions, facilitated by you, helping them to go out there and thrive, that would be a very, very, very good thing in service provision. Let me talk a bit about collaborative partnerships. Right now, we know that in order for the older refugees to thrive, they have to work around resources from the state, resources from the agencies based on the fundings that and the grants that agencies receive. But having these resources given to them in a manner by the agencies who are collaborating together is an approach that would really go a long way in bridging those gaps, because and also avoiding duplicity in some of the service provisions. So basically, that's what in health promotion we call that holistic approach to service provision, where the different agencies combine the different expertise that they can bring. We are now having a big surge of CHEs, for example, and there's certain case loads that are becoming unmanageable in certain agencies. How best do they collaborate with another sister agency? Those are types of the collaborative partnerships that we're talking about. But in this situation, where we're talking about older refugees that need some of these community needs, need some of these referral sources, where can that actually work best? It works best when we're putting our heads together. When agency X is working with agency Y in pulling those resources and tailored towards helping, from resources in mental health, resources in adult care facilities, in senior centers, resources in medical, as well as well-being kind of mental health services. They're all dotted around our states. But we have those services. We have effective ways of delivering them and capacities based on our different agencies. So to have all of us together in a partnership, where we learn from each other, where we, share and help address issues that we are all faced with, is a very, 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 very unique and very good way of in-service delivery. And NJOR actually is planning in next year to try and bring all these partners dealing with this cohort of refugees, older refugees, together in a community of practice, where we then share those experiences, our challenges, and positive aspects of service delivery, in order to help us all attain that one goal. Even if it's very little, but that is enough at least to move the needle a little bit higher. That would be very, 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 very important. Advocacy is also very, very needed. Is needed advocacy, in strength as a whole cohort of service providers is very, 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 very important, because it helps us collectively address some of the issues that we are facing right now as one voice. There's so many asks by the different agencies that right now are needed, especially in light of this big surge of the different refugees that are coming in. But only if we can do this collectively as one voice can we then have that strength in numbers in going to, challenge some of these policies and asking and seeing how best we can work with these, the state, or even above that, working with Congress and all that, because advocacy transcends just working with who we are working with, but goes to our, the people in Congress, and to see how best appropriation committees can then help in the monies that they disburse for certain, services, or, deliver of services. So collaborative partnerships is a very important aspect in our daily, in our ways of delivering services to our clients. Now, I will just quickly dwell on best practices. We should just ensure that our staff are culturally competent, provide language support to overcome communication barriers, develop individualized care plans that consider the specific health, social, and cultural needs of each older refugee, and then implement trauma-informed care practices, recognizing the potential trauma experienced by the older refugees and adapting services accordingly. And then community engagement, very, very, very important. How do we involve refugees in the planning and decision-making processes, fostering a sense of empowerment and community engagement? Right now, you may find situations where decisions are made, top bottom and top heavy, but how best do we involve our communities in some of those decision-making processes? Right now, like I said earlier, we're having those challenges and barriers in refugee screenings, for example. How are we going to involve the communities that are affected by understanding where they're coming from? What are those impediments that they have, be it cultural, being financial, maybe it's transportation? How does that inform us when it comes to the types of interventions we are trying to develop? So that is the engagement I'm trying to refer to. So for all the refugees, we also have to have those kind of engagements where we go and understand where they're coming from, the trauma they have been going through, in order to, inform the type of service provision that we are going to give them. Of course, health literacy is a major problem. Language barriers, different levels of health literacy, education, and all that. So how do you understand them? By trying to communicate with them in ways, based on how you sense their the literacy levels are. We have to understand that. And it's the providers who are working with these older refugees on a day-to-day are able to engage, be it at intake or just definitely during your day-to-day interactions, what level of literacy they are in. So basically tailor services and interventions or education based on that understanding, so that they are not lost in all these programmatic kind of interventions that we come up with, or we tend to come up with, but at least understand where you're coming from. Then I've spoken about social integration, connecting all the refugees with community activities. Then, of course, importantly, training staff to enhance cultural competency with regular assessment and feedback mechanisms. So we also have to prioritize mental health support, recognize the potential psychological impact of migration on these refugees. So in challenge, the challenges are really immense. I've spoken at length about them. I just would like to devote this last session, time left for your questions, suggestions, or answers, if any. You could always write them in the chat, or feel free if you want to get in touch with me later on. That is also okay. But we are here to listen to you, answer questions that you may have, see ways to support you in those different areas as you deal with the old refugees. And yeah, let me leave this for a few questions, suggestions, and answers. Anyone? David says that he's curious to see how others have been successful at increasing program participation among their older refugees. Thanks, David. Anyone can volunteer with an answer there?
Hi, Patrick. I'm Michelle. I met you when you came to our event with SOR at Church World Service. I apologize because I do have a cold. But I work in the refugee health promotion team. And not just for older refugees, but in general, we've seen many people who do get accepted for Medicaid struggle with finding providers, changing their PCP, just navigating their HMOs. So we held our first workshop and we invited this one in particular was for Ukrainians. We invited all Ukrainians that had Aetna, Better Health, or Horizon New Jersey Health, and we got a few participants come. That was Friday, and they were all older refugees. So they definitely had just experiences and were voicing that, they were suffering with like the technological side when it comes to accessing basic insurance stuff. So we kind of created these workshops with them in mind, and we also sent them with a little cheat sheet so they would be able to work on it at home. And we're also offering office hours. So if they have something in particular they can't figure out after our workshops, they can come in or we can help them over the phone. But yeah, we received good feedback for that.
Thanks, Michelle. And yes, I met your team, very great team. I love the work you're doing at iRaise and the work you continue to do. This is an example of an intervention that brings together a cohort of older refugees, together to find a solution of how best to serve them. Sometimes I would argue that, when you do it individualized in an individualized way, it's not as impactful, but it also is helpful. But bringing them together where they all find that maybe they have a common problem, it is easier to address that and probably even bring in a subject matter expert in health to help them. That is something which is very impactful, and I appreciate what your team is doing. Thank you very much. We got 5 more minutes to go. Any other person with a good success story that we just like the one we've just heard? Feel free. It's time to engage.
I can share. I am one of the ELT instructors with CWS, and we have at the lower levels incorporated languages that are similar together in the class, and I think that has helped to support the clients. And I will say that we have served some of the older refugees over the course of the year, and they've gone from zero English to being more confident and comfortable in the language. And so that is definitely a moment of pride, and you can see how they feel that they're not a burden to their family, and so they can engage more in the community. And so that is definitely a service that helps them to be more self-sufficient.
Thank you, Elizabeth. CWS again is doing a great job, and that is an example of empowering. That is an example of bringing them out, learning skills, and then going out there to change the world. I appreciate that example. Any other person? Thanks, Elizabeth. Got 3 minutes to go. I will just end on this note. Basically, one of the agencies that I went to was empowering, had found creative ways of empowering their clients. Just generally, you know, and this was iRise. I had a meal there where some of the communities that find it hard to come out and were like isolated, or, you know, just very hard because of the society, cultural norms and all that, are now working in a kitchen, you know, and then they provide the best meals that they serve to an open cafeteria, while at the same time they are also learning English languages. And then from there, it builds their confidence from the back, learn English skills. And then they also have like other referrals, like the Walmarts of this world, where there are mentors there. Then they move from there to Walmart under a mentor. So that builds their esteem, builds their confidence, leverages on the little social skills they have, but takes it a little bit higher for them. And they go out there and adapt to community. If that kind of, you know, model of work can also be, you know, replicated in the older communities that we deal with, you know, trying to see where they're coming from, try and build their confidence, integrate them into communities, leverage all this, the services that the communities can, referral sources can provide for them. That is a best way or best practice approach to, you know, empowerment. With 1 minute to go, I thank you very, very, very much, all of you, for participating in this session. We have other sessions tomorrow during the day, of which there's one which is specific to also cultural nuances that I'll be presenting on. And if you have any suggestions about this or any needs, just feel free to place it in the chat. We'll be able to get back to you on if it's a situation that needs clarifying on, or if you have any suggestions or needs as you go ahead or go along in your programming, that would actually help us in our work. And thank you again, all of you. We had a group of 17. That was very, very good, very, 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 very important to me and to all of us. And together we can, you know, move and, you know, serve our communities, you know, in the best way possible while wearing an equity lens. Thank you very much. I appreciate it.
Thanks, Patrick.
Thanks,
Thank
Asia.
you.
Thanks, Michelle.